from San Antonio again. We're here at the Society of Thoracic Surgeons meeting, and I'm excited to have Dr. Cherie Erkmen, who is Professor of Thoracic Surgery at Temple University, and Dr. Meghana, who is a thoracic surgeon at Mercy Hospital in Minneapolis. I knew that. So, Dr. Erkmen, you have been all over the program this session, and you've had so many compelling studies out there looking particularly at some of the diversity, equity, and inclusion issues that have been at the forefront this year. Can you tell us a little bit about your presentations?
Yes. So I think that diversity, equity, and inclusion, this is a core value of the STS, meaning that it's so important to advance this and show how we can play a part in diversity, equity measures, inclusivity, and through a meeting like this, we have the potential for a lot of impact. So one of the most important projects over the last year, under the direction of our president, Dr. McGilvery, was the creation of a task force to look at compensation. And the task force wanted to create specialty-specific data and look at compensation with the granularity of cardiac surgery versus thoracic surgery, congenital, hybrid, academic practice, small practices, just a whole spectrum of really important granular data as it relates to compensation.
And is this the first time the STS has launched an initiative of this manner that you're aware of?
Yes, this is the first compensation survey, and there were a lot of mechanics and processes to develop the survey, to create an external consulting group, to make sure that this was data that was going to be handled with the greatest of confidentiality and respect, and also to set out our objectives. And again, I give the task force and the STS credit because going into this compensation study, they knew that there were indicators of salary disparity, and they included questions that helped us understand where the disparities are.
What are an example of some of those questions, would you say?
So the most important is the subspecialty data, because all other data that we've received are mostly from institutions, and they tend to lump together the cardiac, the thoracic, and the congenital clinicians. So that's probably the most important issue, because we can say, yes, we see a salary disparity between men and women, but many people have thought, well, that's because there are more women in thoracic surgery, and so they're driving that disparity. There's not truly a disparity, but with our specialty-specific data, we looked at cardiac separately from thoracic, separately from congenital and hybrid practices, and the disparity is still there. So we have to come up with other reasons. We can't just rationalize it away. We need to realize that this is true data from multiple sources, and we need to do some more assessment and action.
So some of the key findings, other than what you just mentioned, would be, what would you say?
The key finding is when I think it's hard to look at compensation data and to conceptualize it. So the way that I like to communicate it to people is by a comparison of dollar proportions. So for every dollar that a man makes in cardiac surgery, a woman would make, under different categories, anywhere from 76 cents to 80 cents. And in thoracic surgery, it's anywhere from 79 cents to 85 cents. So for every dollar that a man makes in this subspecialty, a woman makes a proportion less. And one of the most disturbing findings was that women between the practice experience from 11 to 20 years had shamefully low compensation. That women who have been in practice from 11 to 20 years actually earned less than men with less experience. And so that resonates with people. That is a call to action.
Sure, sure. Well, we asked Dr. Helder to join us today because she is, as I might have mentioned, 5 years out from training at Mayo and has landed in her second career move at the moment, a very successful one. And I was curious if you have seen in your early career any of the disparities that are being brought to light here today.
Yeah, I think absolutely. I think there's a few things in context, right? So, more and more women are entering the workforce, and especially in cardiac surgery versus thoracic surgery. I think there's more females going into cardiac. And as you're leaving training, you're just, oh man, I have a job. I'm not going to ask how much, we'll figure that out later. And so that first job, that first contract is just about kind of maybe everything else. And that sounds right. Then you don't really know what everybody else around you is making. And I think really when I kind of made the transition to a different job, it was at that 3-year period when I really started asking, what is the differential? I was in a bit more of a unique situation, a true private practice setting, and partly physician-owned hospital. I think then the people that you are kind of negotiating with for the compensation are thinking about kind of what they got paid X number of years ago at an early career stage, which the market is so different now. And to kind of, I think that still plays in quite a bit in negotiating compensation. So I think two things. It's we don't have a transparency at all about. So I think this is great to have something to work off of that isn't MGMA data, that isn't kind of watered down with first year super fellow, salaries included in there, but to also have a talking point that people really need to address on a national level.
Excellent. So Dr. Joel Dunning is hiding behind the camera here, but we were discussing about your findings that in the NHS in the United Kingdom, there is no negotiation. So he said, what do you mean that men and women make differently? Because in the NHS, it's a very well-defined and prescribed salary compensation structure. So is that the answer, or?
Well, certainly that's not a foreign concept to us. No matter whether a chief resident is man, woman, black, white, good or bad, that person receives the same amount as the chief resident who works shoulder to shoulder. So it's not a foreign concept to us. What is interesting is that first job out of practice, that one day you're paid equitably, and then you step into practice on your own and there's an automatic discount because of gender and because of race, which is also something that we've noticed. And it compounds over time. And so there is a known influence, like what are the measures? What can we do from here? And equity of the very first job is probably the most influential step, because everything of disparity compounds year after year. So if you can at least get that first job to have similarities and to get some equity, that you can impact further down the line. And like you said, that you don't have the leverage or the experience to negotiate that first salary. And so this is a service to the members of the STS, that you have this data, you know it, and you can advocate for yourself. But one thing that we can do is actually advocate for others in our group. So this data gives us the power to not only advocate individually, but to work together on the behalf of our membership and of our colleagues to create this equity.
What a great idea, and what a great concept that we should all adapt. So what would you, other than using this data as leverage, as you mentioned, how would you recommend to someone like Dr. Helder, or or someone just finishing their fellowship and heading into that important first negotiation?
So I think having the power of knowledge is important, that you have this data, you participate in this data, and so I definitely want to encourage people to become members right away as soon as they can, to fill out the survey and to contribute to what we have. I think that you also need knowledge that's live and specific to your situation. So finding people and mentors who can give you that insight and perspective is very important. And maybe even people who are from different disciplines or from different parts of the country, because all of that helps you. And that first job of negotiation, hopefully we can get to the point where we can help people with a tool, a checklist. Okay, these are the things that we think a first year attending should ask about, and whether it is the base compensation or time to come to meetings like this, or other ways that you can compensate people aside from just the dollar amount, that having this list, that shared and consistent tool for conversation, that can arm you and also your employer, that they know, okay, I didn't even know that this was important to you, but you're telling me it is, and we can compensate you in ways other than just dollars.
What a great recommendation. Are there next steps for your work here?
Yes, so our data was not robust enough to look at race and ethnicity. So that's a huge gap, and we need to fill that gap. Unfortunately, the representation of African American, Hispanic, and other races, ethnicities are low in our profession, so there's only so much that we can do. So the next steps, get a more robust response. It was about, I think, 23%, and we're shooting for in the 40s next year. And the next step after that is to create this transparent conversation about compensation.
Fantastic. Any other thoughts, Dr. Helder, for your compadres and colleagues facing the same discussions?
I think the idea of having other people or an organization advocate for that negotiation is really important, especially kind of at that first negotiation, because there's a bit of an imposter syndrome, right? So you've been trained to do X. I can potentially do X, but I haven't yet done X, but I am asking for a compensation. So I think that's a really hard step to advocate for yourself. So I think that's really important, to have really an organization that's defining those standards, that would make that first negotiation much easier. Yeah.
Wonderful. Anything else you'd like to share with our viewership?
I wanted to share that a natural gut reaction to this type of data of salary disparity, that we might want to hide it, that it's embarrassing data. But in the context of surgical specialties, medical specialties, and across the country, this is not out of the ordinary. But what is out of the ordinary is that the STS has taken steps to understand it, to be transparent, to study it, and to get to, hopefully, interventions. And so I didn't want people to take away that this is just a sore that we need to hide,
Sure.
that this is something that we should be very proud to understand, investigate, tackle, and go to the next steps.
Wonderful. Well, we're so thrilled with how intentionally you're tackling this and the task force. So thank you for all your advocacy, and great to have you both.